Over the last 25 years, I've had the privilege of interviewing and highlighting some truly interesting people. Everyone who is anyone, both the famous and the infamous, from presidents and their first ladies to kings and queens, movie stars and pop stars, captains of industry, heads of state, sports personalities, innovative entrepreneurs, and some pretty fascinating everyday people. Today, I'm proud to introduce you to Dr. Ramzan Zakir, a cardiologist who sees helping cardiovascular patients achieve better heart health outcomes as his professional calling in life.
I appreciate that, Star. Thank you.
Absolutely, 100%. So, sir, let's start off a little bit by talking about how you decided to actually become involved in medicine.
Yeah, Star. So when I was doing a clinical rotation in cardiology, I recall that day very clearly. I was rounding with the cardiologist, and I remember he got a call from the emergency room to see a patient that's having severe chest pain. So we went down to the emergency room and saw a patient that was extremely uncomfortable, clutching with the fist around their chest, complaining of crushing, severe squeezing pain. We looked at the EKG. The EKG was consistent with someone that's having an acute myocardial infarction, a heart attack. And, we talked to the patient quickly, told them that it looks like the artery is probably 100% blocked and you need to go to have an emergency cardiac catheterization and probably a stent placement. So I was there listening to the attending speak to the patient. We brought the patient up to the cath lab. And I remember I was able to watch the procedure, and the attending quickly was able to open up the artery, put a stent in the patient, and then I was able to assess the patient afterwards. And, the patient all of a sudden felt so much better, had resolution of chest pain. We looked at the EKG, all those changes, the ST elevations had resolved, and just that, that feeling, satisfaction of, being able to help a patient, immediately and intervene and make a difference on that patient really, reflected highly on me. And from that point on, I knew that's what I wanted to do. I wanted to become an interventional cardiologist.
And I'm one grateful person for that. I pride myself as the national volunteer for the American Heart Association on knowing pretty much what a cardiologist does. And I know most people, generally speaking, know what a cardiologist does, but I don't know if they're fully aware of the specific treatments that you're able to provide. We are familiar with cardiothoracic surgeons. We're familiar with cardiologists who can diagnose and help with prevention. But you can now do specific treatments such as revascularization. And as I was reading about that, I was fascinated. Tell us a little bit about some of these little known aspects of your work.
Yes, Star. So that's a great question. So my focus is on patients with complex coronary and peripheral arterial disease. So we're all familiar with patients who come in with heart attacks that require immediate intervention. So what we're seeing now is a lot of patients come in with more complex scenarios where they're elderly and they may have their heart may not be contracting as well, and they may not be good surgical candidates. Their arteries may be severely calcified. These arteries tend to require a different type of treatments where we use atherectomy devices to break up the calcium. If their heart's not pumping that well and they have high-risk anatomy and they're not surgical candidates, in some cases, we put a support device during the procedure to allow us to safely perform these procedures. This is known as high-risk complex PCI. We're also involved, we're going to be involved in a clinical trial to assess these devices in patients who come in with acute heart attacks. And then the other focus is in patients with peripheral arterial disease, and their presentations are often with severe pain when they walk, excruciating discomfort in the calves or the thighs, or they may have wounds or ulcers. And this represents a treated and under-recognized entity. So a lot of these patients get passed off. Some of them, they think they have back issues that are causing their symptoms. And some people are told that they just kind of, got to live with the pain, or some people are told that, an amputation is the only treatment. So it's very gratifying and satisfying to intervene on these patients and really, change their outcomes and stuff. Patients can only walk, short distances. And then after doing this procedure, their, quality of life changes dramatically. And this is, all done through an endovascular procedure, non-surgical. And a lot of these patients with peripheral arterial disease can also be treated in an outpatient setting. So I've been doing this in an office-based setting for years now, safely doing these procedures and, really improving their quality of life and sometimes saving their limbs in certain circumstances when they have wounds or ulcers. And another area that I focus on is the access site. So traditionally, a lot of these procedures were done from a femoral approach. So when I came to Robert Wood Johnson in 2009, and that was the way it was done, is through the femoral artery, the artery in the groin. And I introduced radial artery catheterization to the lab, and they're very receptive. And I was able to build a transradial program at Robert Wood Johnson. And then I became the director of the transradial program. I held courses where other physicians would fly in and come and observe, and actually, set up a hands-on training program for them to learn how to access the radial artery and perform these procedures. And now technology's evolved where even for patients who have blockages in the legs up to the knee, we're able to reach from the wrist. So I've had, a course, pre-COVID, a live course where physicians came in to learn these techniques, how to treat patients with peripheral arterial disease from the radial. And I actually have a virtual course coming up pretty soon.
I have to imagine, sir, that being able to give a patient not just a better outcome, but a better experience as they're going through whatever the treatment is, has to be one of the goals.
That is one of the main goals. Obviously, it's the result of putting the stent in, but also it's the whole part of it. I mean, you could do a great job on the procedure itself and get a great stent result, but if there's a groin complication, the patient's going to remember that, the complication and the hematoma, swelling in the leg, these sorts of things. And if you're able to perform, that same procedure, through the wrist, and be able to deliver a stent, and the patient has minimal trauma, and a quick recovery time, patients love that. The satisfaction is a lot higher on radials than femorals.
Mm-hmm. Well, as I pointed out when we first started our conversation, that you and I would normally be at the American Heart Association scientific sessions during this week. That's right. The Super Bowl for the field of cardiovascular disease. And with COVID-19 just really permeating our society right now in this global pandemic, I have to ask you, in terms of new information, and according to a recent paper that you co-authored, COVID-19 and the resulting social distancing guidelines could be causing a rise in delayed presentation for heart attacks. And I was fascinated when I read this information. Doctor, can you explain your reasoning behind this conclusion?
Yes, Sarah. So what we saw, early in the pandemic was patients, coming in late. They were presenting late, with heart attacks. Sometimes, 12 hours, sometimes 24. And then the rationale, then you'd ask these patients, when you had the symptoms, why weren't you coming in? And the responses were pretty much the same. They were fear of contracting COVID. And so when they get the chest pain, they would think maybe it would blow off, maybe this will pass. I don't want to go to the hospital. And, and some of them, there are a lot of patients who didn't actually make it to the hospital. Yes. I lost a few patients, that way when they started, I heard from the family members, they started having symptoms, and they kind of, said, okay, let's, let me just ride it out and stuff. And so it was very unfortunate.
Yes, sir.
Fear of, getting COVID led to this, surge of, patients coming in late and having more complications from their heart attacks than they would if they presented in a timely fashion.
That's very interesting, because one of the issues, especially as it relates to women and heart disease, is that women do delay going in to get any symptoms checked. Right. Women, as the natural nurturers and the natural caregivers for the family, very rarely want to put their own health, at the top of their to-do list. And so I can imagine that even with COVID-19, that has probably exacerbated the situation.
Right. Yeah. And women tend to have more atypical symptoms, and they also think that they're women, that they're less likely to have a heart attack than a male and stuff. And all those, play in a role. That's a great point you brought up about, women coming in later as well.
Yeah. Well, that's my job for Go Red, is to make women completely aware of our risk for heart disease. So, sir, aside from the findings you noted in the paper, how actually has your work changed due to COVID-19 and the global pandemic?
Yeah, Star. I mean, that first month was, I mean, it was horrible because, all lines of services, everything was shut down. So because the whole emphasis was on treating patients with COVID-19, and that first wave was something we just, never seen before, and hopefully we'll never see again. The acuity of these patients. I mean, they would, one second they'd be okay, and next second they would be so sick, and the mortality of those patients were so high. Even younger patients developing thrombotic complications. I mean, it was just unseen. So, a lot of the cath lab was closed only for emergencies. Patients who come in with heart attacks and who really had to get done, as a staff shifted to cover, the surplus of patients with COVID-19. And then the emergence of telemedicine really played a big role. So we're doing a lot of virtual visits,
Yes.
and I think that's going to be, I think that's going to stick around for a while now. So
I do too. And I think that's the way people are going to be meeting in the future. Virtual meetings. A lot of people think that they get much more work done. But this really begs the question. There's no way we could be completely prepared for what this global pandemic would have brought to our society. But how would you advise future healthcare professionals to prepare themselves for the challenges that await them in medicine? It may not be a global pandemic, but there will be challenges.
right. I mean, I think this was a big wake up call, because the last time we had a pandemic was 100 years ago. It was the Spanish flu, right? And that took about 2 years to really clear out. And it had its waves also, and now we're seeing a big second wave. And I think everybody's awoken now, and I think the clear is to follow your common sense guidelines, and that you'd think that would be easy, but yet the concept of wearing masks and stuff, and when you see people out there saying it's my right, I'm not going to wear a mask, and I mean I think I mean it's disheartening as a healthcare provider who we're doing all that we can, and we know masks work. I mean, let's look at how many of us who are dealing with COVID-19 patients on a regular basis get infected. The infection rates, do people get infected? Yes, but are they all getting infected? No. Why aren't they all getting infected? It's because we're wearing proper gear, and I mean, so to say it doesn't work, I mean, I think is ridiculous. So I mean, I think it's nobody wants to be in these situations, but once we're in it, we all got to come together and work as a team, and follow guidelines and follow common sense protocols, and just bear down and get through it, because we will get through it. This will pass.
Yes, indeed. And Doctor, speaking of teamwork and using common sense, I get the feeling that you got that as a young person. So what role do you think your family has played in your success?
And they played a tremendous role. I mean, so they were, my parents wanted me to become a physician, and whatever I needed, they provided that for me, and I thank them very much. And I couldn't be here without their help. My father was, again, he always told me there's going to be, a constant demand for physicians, right? And he was a civil engineer, and he was very successful, but there was always be surpluses. There'd be like shifts and that sort of stuff. And I guess early on, just understanding just the appreciation people give you as a physician, and that, I think that really honed in on me. There's no more of a noble profession type than to be a physician, is what what he really told me. So I mean, it wasn't a specific thing, because it was kind of grounded in from day one. Pretty much, you are going to become a physician, and and everything kind of fell in place. So there was no really one thing. It was kind of a framework that was put in place, and it just all fell through, and everything, thank God, it just all worked out fine.
So we very clearly see you know how to follow directions, sir. Finally, what is the one thing you'd like the viewer of this feature to walk away with?
I mean, again, so cardiac disease is always been the most common cause for mortality, except for, the Spanish flu. And hopefully we get the COVID numbers don't rise up to rival, cardiovascular mortality over a year. And I think, there's a lot that we can do to help, control our outcomes. I think genetics does play a big role. So, sometimes the deck of cards that we get are not the best, but we got to do whatever we can to control, what we can. And that's, by diet, by not smoking, exercising, doing these basic, these basic things. As an interventionalist, I focus on patients who are at the later stage. So my focus right now, I'm at Robert Wood Johnson. I'm the director of high risk PCI and research. So I focus on patients who have critical disease. And as we get, we have more of an aging population, the life expectancy is increasing. Now it's just under 80 years old. So we're seeing patients who are older with, who are mentally, they're totally, functional. And so we're seeing more complex disease. And that's an area where I focus on. Patients with vascular disease, that's an area where I spent a lot of time. People who have peripheral arterial disease I don't know if their 5-year mortality is worse than breast cancer.
Wow.
So these are a very sick cohort of patients. And by vascular disease, people who have blockage in their circulation to the legs. So that's an area where, I spend a lot of time focusing on is patients who have, ulcers and wounds that are non-healing. And even now, a lot of times an amputation is the first line of treatment that's offered to these patients. So what we found out now is timely revascularization can save limbs.
Wow.
So saving limbs, and so that's an area where I focus a lot on. Is treating patients with vascular disease. So I think early identification of wounds and timely referrals, I think play a big role. So I think all these things, it all starts with living a healthy lifestyle. But what we're seeing is patients live older. We're seeing more diabetes. We're seeing more renal disease. So we're seeing more of these complex manifestations of disease as well. And that's, I'm kind of at that late, the late end, but early on, don't smoke, eat healthy, that's, those are the basic things, exercise. Yeah.
Well, my rule is eat less and move more. That'll start the road to a healthier lifestyle. And I completely agree with you. Actually, we both know that a full 80%, it's estimated, of cardiovascular disease can be reduced by simple lifestyle changes. And of course, not smoking and getting some exercise and eating a heart healthy diet is really the foundation of good health. So I thank you, Dr. Zakir, on behalf of heart disease survivors and heart disease thrivers, as well as the patients that you have just touched in so many ways. Thank you, sir.
My pleasure, Star.